talking about this important topic of how are we really improving safety and outcomes by using benchmark data. And you just heard Chris really talk about the importance of risk stratifying to really understand that benchmarks aren't really an absolute number, but they're a number that needs to be understood in the context of important predictor variables. And Chris and I are partners at UCSF. I'm going to share with you some of our experience at UCSF with some specific benchmarks. These are my disclosures, and I don't think any are relevant to this topic. So a benchmark is really a standardized point of reference, and put into a verb, benchmarking really refers to a continuous and systematic process of comparing current performance markers, so how are we doing now, against some predefined standard point of reference or some predefined benchmark in order to evaluate and importantly to improve performance. And fundamentally, this is a process of trying to improve quality of care, improve safety in complex organizations. This is where the lean processes from Toyota, the Six Sigma processes from Motorola, Six Sigma perhaps being more relevant here, to try and minimize variability, identify areas where there is variability and minimize variability for lean, minimizing waste. And the point here being that there's a methodology to process improvement. So number one, we want to identify the problem. And I'm going to suggest that any area where there's high variation in observed rates is a potential problem. If quality is defined by consistency, then where there's variation, we might want to try and improve processes. We want to measure the cause, analyze the root cause, and then have some intervention addressed to those root causes, and then subsequently implement the intervention. And the important part of this is to go on and remeasure. So again, in terms of defining the problem might be when our observed rates are something different than what we might expect. And that creates the need for benchmarking. And a lot of this work has been done through the Lancet Commission in general surgery, and looking at what is the evidence, what are some solutions for improving health, welfare, and economic development across surgical programs. And some of the metrics that they had suggested, some of the core indicators of quality include things like access to time to surgery, or how well do patients access surgery, do the patients have access to a surgical specialist, surgical volume, and protection against impoverishing costs or excessive cost out of pocket. Those are worldwide issues in surgery. And another metric that they put down there as a core metric is the idea of mortality. So having some mortality rate that is a benchmark that we ought to really compare surgical institutions across the country to that benchmark. The trouble with a benchmark suggesting a mortality rate is what we ought to be using as a target or perhaps as a floor, is that is what Chris just talked about, is risk stratification. So going beyond just global benchmarking of mortality rates, but actually looking at trying to risk adjust these mortality rates. And that's really what introduces the idea of the NIST calculator, and Chris alluded to this as well. But to go into some more detail about this, many of you are familiar with the NIST programs. This is over 800 hospitals around the country now with over 3.5 million patients enrolled. And looking at some of the risk stratification for benchmarking, the calculator takes into account some demographic variables, so age, gender, BMI, some procedure-related variables, and this is where it gets quite interesting, is putting in CPT codes, and I think there's a disassociation between our CPT codes and actual surgical invasiveness. But having said that, put in CPT codes for different procedures and looking at some specific factors that might be risk factors for complications. So a Charlson comorbidity score, smoking, diabetes, other comorbidities. And with that, using a calculator, and I'm not going to do it as a live version, we can link it here, but it won't work. So I put up a couple of examples. If I put in a osteotomy in the spine, 3 columns, and put this in a patient who's under age 65, normal BMI, minimal comorbidities, we say, well, your chance of a serious complication here is somewhere around 8%, and chance of death is really quite low. Chance of a surgical site infection, 1.4%, for example. I don't have neural injury on here. But if I change those metrics to somebody who's an octogenarian, with non-independent diabetes, who's also a smoker, and put in a few other comorbidities, suddenly your chance of a serious complication for a 3-column osteotomy is almost 30%. Your chance of death is now more than 1%, and all of these complications go up quite significantly. So again, to establish a benchmark, we really need to risk stratify and to know what factors are associated with complications. So it brings up the question of what is an acceptable risk, or what benchmark should we use? And what we want to find out is what is the expected rate, so that comparing that ratio of our observed experience to what's expected, that gives us some meaningful metric of quality. And again, requires accurate information about risk stratification. And I'll get into that a little bit more in the UCSF case examples. But I want to give just as one example, looking at complications. So we've all been looking at complication rates, and the broad spectrum, if we were to say, well, what is the expected rate of a neural injury in an adult deformity surgery, for example? Well, we did some work with the SRS M&M committee, and that suggested that in terms of a neural injury, we'd expect between acute perioperative neural events and delayed neurologic events, maybe 1.5% of patients undergoing surgery for deformity out of 5,000 patients, 1.5 had a neural injury. So we'd say, well, golly, that's a pretty high standard, but I'm going to make that my target. But when we actually get into some studies to look at this in more detail, including the scoliosis trial that Larry Lenke led, we see numbers more like 23% of patients in the immediate perioperative period in a 3-column osteotomy or in a major surgery, major reconstruction, had some neurologic deficit. Or this work by the ISSG, very similar, about 27% of patients had either perioperative or delayed neurologic complications in adult deformity surgery. So establishing a benchmark is awfully important, and trying to have some accurate rates is what becomes challenging. And that's where it's so incumbent upon us in collecting data to really present data as accurately as possible. So why is there a need for benchmarking? Again, or where's there a need? I think metrics where there's high rates of variability. Rates of surgery, for example, what's an appropriate rate of surgery? Mortality has been a lot of work done, especially in general surgery, on mortality rates. Length of stay, and I'm going to show you some of this data, length of stay, perioperative complications, and protocol compliance. So those are all areas where there's high rates of variability, and a benchmark might indeed be useful. So I'm going to wrap up my time with a couple stories. So telling stories from our institution. Michelle's here, so I'm going to let her tell the story of the HARMS study group. I won't include that in my talk here. But here are some stories of some things we've looked at: reoperations, readmissions, length of stay, and we also did some interesting work with costs. And it all started by looking at some outliers and understanding that outliers and eliminating outliers is an important part of improving quality. It brings us to thoughts about Wilfred Pareto. So Wilfred was an Italian economist who actually studied and worked at the University of Vienna. And he looked at land distribution and the suggestion that 80% of land in Italy was owned by 20% of people. And he gave that as an example in the 19th century as a tremendous inequality, a tremendous iniquity in terms of land distribution. But healthcare is actually just as bad or worse. If you look at healthcare, in terms of an inequality of distribution, about 80% of healthcare expenditures are within the top 20% of the population. And fully half of healthcare expenditures are accounted for by 5% of the population. So again, some terrific disparity, and that's where paying attention to outliers makes sense. And I'll show you an example of that soon. So here's some data from UCSF. This was over a period of time looking at length of stay 2 years ago now. The mean length of stay was 5.5 days. Now, what does that tell you as an absolute value? That tells you absolutely nothing. If we're an ASC, then that's absolutely horrific. Whereas if we're seeing patients with inpatients with tumors or transfer patients, it's hard to know what the standard ought to be there. But what was established based on our case mix index is that number ought to be about 4 days. The trouble for this is that what actually happens in a lot of cases, patients are coming in preoperatively and staying for some time preoperatively. So then we developed a metric of, well, what about post-procedure days? Because when we're transferring a patient, we often can't control what happens preoperatively. So post-procedure days, we were actually a bit closer to the benchmark than overall length of stay. And we also did some predictive analytics working around this. Our Center for Computational Health looked at some variables, including healthcare coverage, race and ethnicity, osteoporosis, age of the patient. They're actually quite predictive. And finally, a RAPS score, quite predictive of length of stay. So this information led directly to actionable changes. And what this information led to, the fact that our length of stay was higher than the CMI projected, led to us getting hospital funding for a nurse navigator, led to some preoperative optimization programs done through our preoperative clinic as well as our spine clinic, led to the utilization of RAP scores. This is a patient's ability to rehab after surgery, predicting that preoperatively. It led to having inpatient hospitalists involved in our patient care, and it led directly to support some ERAS protocols and administrators for ERAS protocols. So we were able to use that data, use that benchmark to try and improve our numbers, and we have. Here's another area that's interesting is order set compliance. So everybody's got some type of electronic medical record and you put in your order set. We found that about 79% of people, in 79% of cases, people were compliant with a perioperative or preoperative order set, which was actually pretty good. Now, having said that, Chris and I and a number of us, we use different order sets, but this is one of my preoperative optimization pathways. So every patient who has an elective spine surgery, I type in .preop-op and this comes up and I get information about their blood sugar, bone health, BMI, infection risk, smoking, narcotic utilization, their frailty, and I'm able to look at this and see where are the things that I could optimize before surgery. And this is something that we can create into an order set and try and get some compliance and actually improve compliance with preoperative optimization, knowing that when it becomes an order set, 79% of people will actually implement that. We did some work on readmission data, and our 30-day all-cause readmission 2 years ago was 5%. We reduced that to 3%. And part of that was, again, we identified that this was higher than what we wanted at 5%, and certainly under bundled care initiatives and shared risk programs, this was a big problem economically. So we, again, developed preoperative optimization protocols. We worked on getting patients to home. We found that patients were 11 times more likely to be readmitted within 30 days that they were discharged to a SNF than home. So we worked on protocols to get people to home. Medical co-management on the floor made some difference, we think, and also access to outpatient evaluations. So rather than somebody having to come in through the emergency room, that they can actually have access any day of the week to the spine center, either virtually or as an inpatient visit. And that significantly improved our readmission rates. Another area we looked at was the cost of care. And specifically, we found that overall spine at UCSF, our average cost of care was about $45,000 per case. And when you add to that, there's a lot of snake pit I put here, a lot of controversy about what to do about indirect costs. But we were able to, the metric that we benchmarked is we said we'd like to have a contribution margin, which is revenue over direct costs of 40%. And that would cover the indirect costs, and actually that was the target that we set. And we were able to reach that over the course of 2 years, where we did a lot of work with materials management. We modified our formulary. We took out some outliers of more expensive implants that people weren't using, created some price thresholds for bringing in new implants, and we did some active management with regard to length of stay. We were able to improve the contribution margin quite remarkably, and I could tell you that before this project started, I had no idea what contribution margin meant. Still know a little bit less than I should, but having said that, this is a major metric for a medical center. And again, in some of this work, we also looked at where are the real bundle breakers. So if we get a certain amount of money as a payment from CMS for a DRG code, well, we identified cases that were bundle breakers, and almost invariably these were patients who really weren't optimized before surgery. Now, in a lot of these cases, they weren't optimized because they were emergent cases, but in some of these cases, they could have been optimized better. So to that end, I think understanding what our metrics are, either financial metrics or complication metrics, can be really valuable. Now this next part, I recognize that Michelle is going to cover much more thoroughly, but worked through the harm study group, and I had some slides that Peter Newton had lent me, but Michelle's going to show those. But some tremendous evidence suggests that in adolescent idiopathic scoliosis surgery, they can really reduce length of stay, reduce blood loss, reduce operative time, and Michelle's going to show you that data. So I'm going to wrap up by suggesting how can we use benchmarks to improve quality in our hospitals. Well, one is set meaningful goals and figure out what your goals are going to be it a financial goal, a complication rate, but set a goal. use data to identify opportunities. So I think there's always opportunities in areas where there's variability. Create an infrastructure to collect the data accurately, and then compare within institutions, compare between institutions, and in those comparisons identify, well, where maybe there be deficiencies, make changes, learn from each other, and then repeat the process. And to that end, I think we reliably use these benchmarks to try and achieve an appropriate target for better quality care. So thanks for the opportunity to contribute.